This
Did you guys hear
conference
it?
will now be recorded.
Now I heard it. There we go. All right, gentlemen, this is the AnCan Low and Intermediate Risk Prostate Cancer Group. I'm Bill Franklin. You have three other moderators here tonight, John A., Stewart, and Boykin. And so this is a group to discuss people that have fairly low or intermediate prostate cancer. So we do discuss treatment in this group for people that have had it, and we help other guys maybe decide on something that they might want to do. We do not give medical advice because we are not doctors, with the exception of John, who is a doctor. But he won't give you medical advice in the context of like being a physician for you. He will give you his opinion on medical advice. So we have several sponsors that sponsor AnCan that we would like to thank. Some of these are pharmaceuticals, some of them are other medical related organizations. We don't advocate any particular drug. We don't sponsor their drugs. They sponsor us as a patient advocate and information kind of group. So we may discuss something that they make or do because they provide treatments for prostate cancer. So they are Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Blue Earth Diagnostics, Foundation Medicine, and Telix. So with that out of the way, over here. So we have three new guys today. Jeff was the first one to log on. So Jeff, if you tell us a little bit about yourself, we'll ask you some questions. Our first question is always the one that some guys want to answer, some guys don't. First off, how old are you?
I am 61 years old.
61. All right.
Mm-hmm.
I'm 61 also. I'll be 62 in a couple months. So.
And same for me. November 22nd.
November 6th. There you go. So where are you calling from?
Louisville, Kentucky.
Louisville. All right. We don't really care where you're calling from, except in the context of we may know of some medical organizations or facilities nearby that specialize, centers of excellence and those types of things for prostate cancer or other conditions. So we like to ask. So I got some very good friends that live in Cave City, Kentucky.
Excellent.
All right. How'd you hear about AnCan?
Well, I've been following the discussion group, Mayo Clinic Prostate Cancer Discussion Group, for a while, and I saw that you guys were referenced there.
Oh, I'm glad someone referenced us. It's nice. Oh, yeah. My screen went flaky again, guys. Sorry. All right, I'm back. All right, so I have to ask: have you gotten a diagnosis of prostate cancer, or are you like in the preliminary stages? Or?
No, I 4 years ago I was diagnosed and have been on active surveillance the last 4 years. 4 years ago, it was just a tiny amount, 12 core samples, one sample, 2%. I'm saying stuff off the top of my head. I hope it's right.
Right.
One sample, 2% was positive. 3+3, they did the biomarker thing, OncoDX, and said very low likelihood of ever spreading. So that was 4 years ago. And since then, I've just been, going back, under the care of a urologist. And I got to this point because I have two older brothers. Both have had prostate cancer. One, it had already metastasized before he knew about it, and he ended up passing away with it after so many years. And then the other one probably was where I was 4 years ago, and he chose to have the prostate removed, and he's doing just fine now. So that's why I was going. I wasn't really having problems, but that's why I was going to a urologist because of what my one brother had gone through.
All right. So you're still on active surveillance? Is something changed that led you
Yeah,
to here to us tonight? Or?
yeah, it has. So, w- the urologist I was under the care of, his method of active surveillance, which, I don't know enough to say that it wasn't right, but his method of active surveillance was PSA every 6 months, and that was it. And last year, I just decided to get a second opinion from another urologist in town, and he did an MRI, or he had an MRI ordered last year, and it was completely clean. Found nothing at all, and so that was just great. And his plan was 1 year later, which would have been like May or whatever of this year, he was going to do a repeat biopsy. And I just got really lucky. Um, my employer has this new benefit where if you have certain diagnoses, they'll send you to centers of excellence. So I thought, rather than having it done locally, which they're just fine, I would go ahead and take them up on that. So I went to Mayo Clinic and I had an MRI done in July. And the MRI, again, I'm saying stuff off the top of my head, it found no spread whatsoever. It found one spot that seemed to me to be big, but the doctor didn't say it was so big. One spot that was 1 centimeter. And and that was Mayo Jacksonville. And the doctor there said, we can do one of two things, either a repeat MRI, and I believe he said 14 to 18 months, or you can have another biopsy. And I just decided to go ahead and get another biopsy. And for the biopsy, I went to Mayo Rochester. And I had that done last month. And surprise, surprise, it had gotten a lot worse. What I saw on the MRI was not what I'm seeing on the biopsy. I meet with my Mayo nurse practitioner in a couple of days to go over it, but just, me as a layman reading it, and this is where I have to refer to my notes, I wasn't planning on speaking, but there were like there were six that were positive. They were 3+3. Four of them were 3+3, and two of them were 3+4. And so when the biopsy was done 4 years ago, and I'm probably repeating myself, there was just the one that was 3+3, but now I've got two samples that were 3+4. And one of them, the worst of those, and I think it's probably important, it says it was 60% of the core was showing, I guess, positive tissue. Yeah. And
Right.
the other things, just reading the Mayo discussion group that I think it's probably important. And I'm not sure, and I'm gonna get any of this right, but on the report, he said that of the ones that were 4, it was less than 10% were showing as 4, and none of them showed the two bad things that you look for, like cribriform. It had no mention of cribriform. And then
Okay.
there's like another word like IDC or IDP or whatever that is. That was not mentioned on the report either. So that's kind of where I am.
I don't know let me just ask you what that term means, because I've never heard it.
The IDC.
No,
Carcinoma.
the cribriform.
Cribriform is. Correct me if I'm wrong, Rick. It's when they look at the biopsy slides, cribriform has a particular pattern that they look for. There's prostate cancer, and then there's prostate cancer that's cribriform. Did I say that right, Rick?
You did kinda, because there are unfortunately now many patterns of cribriform. It's complicated. We'll put a link in the chat window for the newbies. The chat window are the two little boxes next to the little man with a 16 or a little person with a 16. And we'll put a link in there which does a great job in a fairly patient-centric way of explaining cribriform. And there are many, many patterns of cribriform. But it is essentially, think about it as a cell that kind of looks like Swiss cheese with lots of little holes in it.
Yeah, and cribriform, and I'm sorry, Rick. if they find cribriform, it's more concerning. So the fact that
Well,
yours had none.
if they find cribriform, they automatically grade it a 4. But there are more issues here, which I'll leave. I've put a couple of notes to Bill in the chat window and the moderators. So I'll leave them to answer. But there's some unanswered questions we have to get answers to, and then maybe we can give you some guidance, and some of the other guys can chip in as well.
Yes, Rick put 2 things down that you guys can't see in the chat, but they're on my list of questions to ask. So
Okay.
So the first one is, do you know what type of biopsy you had? Was it transrectal, or transperineal?
Transperineal.
Perineal, okay. And have you gotten a second opinion on your biopsy from anybody?
No, sir, I have not.
Okay, so we always recommend a second opinion, and we have resources that we can give you the names of, and if somebody, that's the other thing I thought about that earlier today. I should have it ready to just paste into the chat, but I don't have it. Well, someone else will paste it in the chat for me. Let's see.
One of your co-moderators.
One of my co-moderators will post.
And it will appear momentarily. It's not me,
Yeah.
but I have a thumbs up from somebody, and I see 2 of them working on it right now. And watch the chat. There will be 2 there in a blink of an eye.
Yeah, so there's 2 different places. We recommend people use one of them for a second opinion on their biopsy. They're both, one's probably the preeminent prostate cancer biopsy pathologist in the country, and the other's also one of the top rated. So Jonathan Epstein, and I forget Dr. Zhao's first name. But,
Ming.
Ming Zhao, that's right.
Probably the world, Bill, not just the United States for Epstein.
Jonathan Epstein, according to Rick, is the world's foremost pathologist on prostate biopsies. So. Yeah, and I'm sorry, just a minute.
And Bill, when you say you recommend getting a second opinion, you're not referring to a second. Are you referring to a second reading of the same biopsy by a different doctor?
So it's a second reading of the biopsy slides, right? We're not recommending getting a second biopsy. So
yeah.
So you would go to the doctor who did your biopsy, and you would request that they send your biopsy slides to one of these 2 individuals, and then it's usually covered by medical insurance. If it's not, I don't believe it's very expensive. And then they'll send it off to them, and you'll get a response. They're both very, very responsive. It won't be something that takes weeks. It'll be fairly quick. So did you see the chat window, Jeff?
I did not, no.
Yeah, so as Rick said, it's the 2 little speech bubbles next to the person with the number 16, and they've posted the first link in there for Dr. Epstein, and then the second link for Dr. Zhao.
Great, I see it now. Thank you.
Yeah, so you can either just click on those links and they'll open in your browser, or at the top of the chat window, there's 3 little dots that are vertical. If you click on those, another little drop-down menu will open, say download chat messages. That'll download everything in the chat window into your downloads folder on your Windows machine. If you've got Windows, if you've got a Mac, I don't know where it goes, but it goes somewhere.
Yeah, no, I'm Windows, so.
All right. Does anybody else have questions for Jeff? Or Jeff, do you have questions for us?
I'd like to know the current PSA test.
Oh yeah, you didn't tell us what your PSA was.
Yeah, my last PSA was 2.4.
And what's the lowest it ever got?
It had bounced around over the last 4 years or 5 years. I started out, let's see, it went anywhere from 1.8 to 5.7.
Okay.
Um, yeah, yeah.
Rick?
So, Jeff, it is Jeff, isn't it? Am I right?
That's
We're
right,
Yes.
speaking
Rick.
with
Yeah.
Jeff.
Yes, good. Um, Jeff, couple of questions. First of all, have you had a germline or inherited mutation test?
I have, I mean, I think I have. There's like the color, what was the company called? Like
Yep.
color,
Color.
some
Yep.
premise, something like,
Yep.
yeah. And you spit in a tube, send it off, and
Yep.
they said nothing. I inherited nothing.
Okay. Good. Second, um, I'm curious why you switched from Jacksonville to Rochester.
Yeah, I didn't really want to. It was kind of surprising. My physician in Jacksonville was just like excellent. Todd Eigel, I think is his name, and he had ordered the biopsy. Even said in his notes while he's in town, try to get it done this week. His nurse said, "Yeah, we do them 5 days a week. Let me go ahead and just call the
Mm-hmm.
pharmacy for the antibiotic." And I went to scheduling, and scheduling said, "No, we have no biopsies whatsoever available on the schedule." Not that I was unhappy with how far out it was. They just said zero biopsies on the schedule whatsoever. So Mayo Rochester was doing them basically 5 days a week.
Okay. Now, who is the ongoing care going to be with? That's my bigger concern.
Well, um, when you say care, Rick, are you talking about any treatment or care after the treatment is all said and done?
I'm talking about treatment discussions and who's going to review the biopsy with you and where are you doing that? In Rochester or
That's
Jacksonville?
there. Rochester, yes,
Sorry?
sir. Yeah, I've got it. In Rochester, yes. I have an
Okay.
appointment this Thursday with the. Mhm.
I would cancel that right away. Number one. Number two, I wouldn't do it with a nurse practitioner. You don't want to be speaking to a nurse practitioner about this. I would make an appointment back with the the urologist you really liked in Jacksonville. So there's a couple of things here. First of all, at AnCan, we're not big on Rochester because they like to cut. They they are known as cutters.
Mhm.
So that's huge. Secondly, we know that the docs in Jacksonville are in favor of active surveillance, even with men on 3+4. Not every one of them, but many of them are, and we know the ones who are. But if you've already been assigned a guy and you like it. Thirdly, under no circumstances do you review your biopsy with a nurse practitioner.
Mhm.
They may think they know a lot, but they don't know as much as the urologist, and this is huge. And it's one of the reasons, again, why we don't like Rochester. So one of the big problems at Rochester is that the groups are very much in silos and they don't work with each other. We don't see that in Phoenix and we don't see that in Jacksonville to the same degree. So it's just wrong to have you discuss your biopsy with a nurse practitioner. Nurse practitioners are fine if you're not at a decision point. So if you're in ongoing treatment and your doc's busy and you're just continuing, you'd be doing active surveillance for a year or so, and you're wondering, you did a PSA test and you want to talk, fine, go to a nurse practitioner. If you've got a decision point coming up, no way. And I personally think it's inappropriate. And I'm in two minds whether even to drop a line to Dr. Heath, who is in charge of all the GU medical oncology there, because we know her well and she's lovely and we really like her, and say, Dr. Elizabeth, why are we referring newly diagnosed men to nurse practitioners to discuss their biopsy on the first appointment? It's
And
inappropriate.
just to let you, and just to give you a little bit more info, Rick, in order to get the biopsy at Rochester, I had to have an appointment with either a physician or a nurse practitioner so that they could order it. Jacksonville was not able to order a biopsy in Rochester, so that's how I got started with a nurse practitioner there. So at the time of my initial appointment, when she ordered the biopsy, that's when they scheduled the follow-up.
Yeah,
So
but you see,
that's kind of a,
but this is the problem. What was your appointment? With Jacksonville? Chopped liver? Why have you got to go see? Why have you got to go see? Talk to somebody else when your Jacksonville Mayo doctor is referring you. I would say one of a couple of things. Get your biopsy results. Pick them up. First of all, you definitely want a second opinion on that biopsy before you talk to a nurse practitioner anyway. Because what happens if Epstein or Zhao look at it and they say, you know what, you've got 6 cores of 3+3. Then we got a whole different ball game.
okay.
We, as a matter of course, we almost always suggest getting that second opinion from one of the 2 of the best eyes in the world. By the way, Dr. Zhao was trained by Dr. Epstein. More than that, let me just silence. Bit of feedback from Bill.
I got him, Rick.
More than that, until you have that confirmed 3+3 and 4 and 3+3 and 2 and 3+4, I don't see that it's that solid to have the discussion with the doc. Now, Dr. Epstein or Dr. Zhao will talk to you. They'll actually, it's not strictly true that pathologists live in a cave. If you talk to the right pathologists, some of them come out their cave and they'll talk to you about your biopsy results. And if you want to talk to Dr. Zhao or Dr. Epstein before you see the nurse practitioner, or hopefully the urologist, you're in a much, much stronger, because we always say at AnCan, be your own best advocate. That means informing yourself. That means getting a second opinion on those biopsy slides. And then set it up. Now, you're in Kentucky. There are other centers of excellence. You don't have to tie yourself. They did a transperineal, fine. You don't have to tie yourself into Rochester. But you already see what's going on in Rochester. They won't even rely on a guy within their own system to refer you for a biopsy. They've got to assure themselves you need a biopsy yourself. It's crazy. If it was Dr. Joe Schmo from some community care practice in the middle of West Virginia, or or somewhere in remote Kentucky, fine. But you went there, you saw a guy, you liked the guy, and Rochester won't accept him? That's bullshit. So that's my 2 cents. And and if you want us to help you find, I would say go back to Jacksonville and make an appointment with the doc you like, since you already like it. after you have the second opinion, or if you want to find another center of excellence that's in your area, we can help you find some good urological oncologists there. Are
Part
you a
of
vet
my
by
decision.
any chance?
Say it again, please.
Are you a vet?
No, sir.
Okay.
See, he asked you too. So, and I'll tag on to what Rick said, and he's telling you what he's telling you is going to take more time, right? And we know, everybody in this room knows that when you've got this diagnosis and when you're thinking about this, there's a sense of urgency. But we also know, the moderators here and some of the gentlemen that have been in this group for a while, we know that based on what you told us, you're not in a rush. This is not something you got to get taken care of next week or next month. If it takes you a little bit of time to get the right doctor, you have time. You're not in any danger at this point, in my opinion. So, and based on what we know from talking to many men in these groups. So
So the 3+4 with 60% of the core positive, that's bad. I mean, it's not great. Nobody wants it, but it's not like super urgent in your opinion.
in my opinion, I'm sorry, go ahead, John.
I was going to say I could take the question if you want.
Yeah, go ahead, John.
I thought you hesitated at first. It's John. You are at kind of a decision point. So I think it would be just great if we could have a biopsy reading that we really like and have confidence in. Because if you have a 3+3 or a 3+4 with less than 10% 4, and your trajectory of increase in PSA is very slow, then you could probably stay on active surveillance for a while longer. On the other hand, you've gone from a negative MRI to a positive MRI in a year and a half. And if the reread of the slides turns out that you 75% 4 and your PSA is still increasing, then you might have to consider radiation treatment. So that's why Rick says that you are at a decision point right at the present time.
So right, yeah, not to be contradictory, but I guess my point was that I don't want you to worry that we're giving you all this advice to do things that's going to take a little bit more time. You've got that time, based on what Rick told you, based on what John told you. So, but by all means, get it done, of course, right? But and be your own best advocate and be proactive. But
yeah, and it's that sense of urgency that caused me to go from Jacksonville to Rochester. I mean, I got to know all the schedulers by first name in both places, trying to get a biopsy somewhere, and they're just, in my opinion, world-class care in Jacksonville. I think they're just overwhelmed with patients. You know, 6 weeks to get an MRI, no way to get a biopsy, and the ease of access at Rochester was completely the opposite. So that's how I got to Rochester. And like going forward, that's another fear of mine that, you know, again, I'll say his name because he was great. Dr. Todd Eigel in Jacksonville is wonderful. If I could just continue with him and, you know, whatever the next step might be, if it's being able to get on the schedule is comparable to Rochester, then Jacksonville is great. But if it's, again, we can't get you a biopsy, period, or whatever the next step is, radiation or whatever, then for me, that's a reason to say no to Jacksonville. It makes it that much more difficult, is all I'm saying.
One of the things that tells us how much of a hurry you're in is how fast the PSA is changing. So you're 2.4 now, and what was the last one, and when was it?
I'm gonna have to go back to my notes,
Okay,
John.
well,
I'm sorry, but I
go
want to
back
say,
when you have time, but I know that at some point you were at 1.8. If it took 2 years to go from 1.8 to 2.4, that's slow. So you don't have to really rush to treatment at all.
and I have my notes here in front of me. Let's see, on June 21st of 2024, it was 1.88. And 1 year later, between that time and now, it had gone up to 4.37, but the last was 2.4.
You mean it was 4.37 sometime within the last year?
Yeah, 4.37 was in January.
Well, then it has fallen. So that's even more reassurance that you're not in a big rush.
Yeah, I put that down in my notes, John, that his PSA had come down from what he had told us was a previous high. So,
Yep.
and at your age, 2.4 is right in the normal range. So,
Jeff,
Right.
did you by chance have any other prostate issues?
No, sir.
Prostatitis or any
like BPH or
prostatitis?
No, sir,
Something
not at
like
all,
that?
Stuart.
Okay.
No, it's
Just
always been
because
a mystery.
your PSA spiking up and coming down can be for a lot of other reasons having nothing to do with the cancer.
Yeah.
Rick's got his hands up again, or hand.
Yeah. Did you have COVID by any chance?
No, sir. My spouse tried really hard to give it to me, but I said no both times.
Look, let me just give you a frame of reference here. When I got diagnosed, I was stage 3, T3A, 4+4, and my PSA was moving by the day. And my doctor still said to me, you have, I was diagnosed, I was confirmed in the August, and he said, you still have until the 4 months until the end of the year. I'd like you to make a decision before year end. So I know there's a lot going on, but you've got to get the right information and you've got to get to the right people. And if it were me, I would not want to be treated in Rochester. Phoenix, Mayo Phoenix, yes. Mayo Jacksonville, yes. We know the doctors there. Mayo Rochester, no, because we don't. I personally don't trust the urologists at Mayo Rochester. So I think we have to keep going, Jeff. Please come back. Please talk to us. We can give you plenty more information. But for me, the first thing on my agenda would be to call Rochester and have them send those slides to either Epstein or Zhao. And then when you get those results back, decide who you want to talk to the results about with those in hand, with that reread in hand.
Thank you so much, Rick. I appreciate that.
And yeah, so Jeff, yeah, that second opinion. And if you didn't, have you captured it out of the chat window? And if not, then for you new guys, my email address is in the chat window also. So if you miss something or you think later that, oh, they said something in the meeting, just feel free to send me a message and I can clarify it or go back over something with you. So
Well, thank you.
Jeff, have you signed up for the notifications? Or do you
Yes, I
want to
have,
give us?
Stuart. Yes,
Okay. So we have
yes,
your
sir. I'm
email
getting.
address.
all right. All right, so we still got two more new guys. Tam, you were the next one on my list. If you're willing, now that you saw what Jeff went through, are you willing to talk to us? You're muted still. We can't hear you. You're muted.
There we go. Is that
Yep.
better?
Yep, we got you now.
Okay. First of all, a shout out to Rick because I've met Rick a long time ago. I'm in Phoenix, Arizona, but I used to be in Tucson, and I met him in Tucson. Um, and so, hello, Rick. Nice to see you again.
Oh, damn.
Yeah. You might remember that my daughter was in Wales studying, and we had a conversation
Oh,
about that.
yes.
Yeah.
Oh, yes.
Yeah. Anyway, here I am in first time in the group. I was diagnosed a few months ago. Um, Basically, I have had a history of BPH for many years. I was being followed and watched by my urologist, um, and was not anxious to do anything about it because I have other things to deal with. I take blood thinners, and that complicates anything. So I wasn't rushing to do biopsies or anything else. He was content to wait. Then I moved to Phoenix, and I'm seeing a new urologist, a guy named Bruce Kletcher. I don't know if you know him, Rick. Um, and I've been very happy with his handling of my case. Um, what happened is my PSA, after being high for a long time because of the enlarged prostate, it started to spike last year, and it went up to from about 14 to 18, and then it was redone and it was 22. He did something called an ISO PSA reading also, which indicated a problem. I was sent for an MRI, and the MRI came back with some PIRAD scores that were concerning, a 5 and some 3s. And then I was scheduled to do a biopsy. And I did the biopsy, and the biopsy came back positive with some several 3+3s and several 3+4s or 4+3. So kind of sitting at, I guess the overall score was 7s for several 7s and several 6s, and so it was concerning. Obviously, very, what you said about rushing to do, needing to do something and wanting to do something, being scared to wait, all those types of things. Actually got news from the from the MRI while I was traveling, so it was not fun. Um, and so after consulting with my urologist, and he referred me to a radiation oncologist that he's associated with, and we've decided that because of, I should mention, I know you guys ask about genetic situations. I have been tested for genetics, but I haven't gotten results back yet. That was done recently, and my brother and my grandfather. My grandfather had prostate cancer, but very late in life, in his 90s. Um, my father had cancer, but not of the prostate. So there's cancer in the family. My brother had prostate cancer and had a prostatectomy uh, years ago in his 60s. And so he's presumably okay, although that's not a picnic at all. And because of my situation being on blood thinners and my age, I'm a little bit older. I'm 75, and not a good candidate for major surgery. So what, and according to what I found and what I was told is that the treatment procedures of ADT, hormone therapy, in conjunction with radiation therapy, would have uh, comparable results to surgery, and so that's what we've undertaken to do. And I've started ADT. Uh, they're looking to reduce the size of my prostate to enhance the accuracy of radiation therapy at the end, which would happen at the end of the year. Hormone therapy, I guess, typically do for several months. to let it take effect and to arrest the cancer. It also has an effect to shrink the prostate. But my urologist was also recommending, and radiation oncologist also was recommending a procedure called PAE, which is a procedure to cut off the blood supply to your prostate and shrink it. It's interventional radiology and considered minimally invasive, and so I'm waiting to get that approved. I haven't scheduled it yet because they're investigating some historic uh, difficulty with my veins, and I'm still waiting to make sure that the tissue that they're looking at is historic and no new clotting issues going on before I rush to do any procedures. So that's kind of where I'm sitting. I started the ADT. Doesn't feel like anything yet, which is great, but I assume, I don't know if anybody's had drug therapy before. I suppose it's something that builds up and you can develop symptoms later or side effects later on. So I'm in that position of being on this drug called Orgovex, if anybody's interested. It's a daily pill, and the prognosis my doctors tell me are good. Um, this is I don't know what everybody else's story is, but this is the first time I've had a situation where I've had to deal with a team of doctors who were to get everybody to talk together and communicate, and it's like all of a sudden I have a team of people talking to me, which is rather different than my problems have been in the past. But I'm happy with people I've met. Everybody in the team, coordinated by my urologist, seem great um, and very caring and supportive. So I'm happy with that. I'm happy that I'm in Phoenix because I think in Phoenix there's more options and kind of like, I guess, that people have more experience than I was living in Tucson, and there were relatively fewer options for people to see. So that's essentially my
All right.
story, and I'm kind of
When did you start the Orgovix?
a week ago.
Oh, it's okay. Just so
Yeah,
basically September of this year, right?
yeah, yeah. And
All right.
I'm have to do a rescan of my legs to make sure nothing is going on that would be concerning uh, vis-a-vis my clotting issues, because I have a genetic issue that I seem to have inherited from my family um, that would gives me a propensity to clot too easily. So I've been on Eliquis for years, and I was on warfarin for years. I haven't had any problems for about close to 20 years now, but in terms of clotting. But I've been on blood thinners,
All right.
and so that's kind of
Well, you were pretty
what my situation.
comprehensive with all the information. Did you get any other kind of scans besides the MRR? They didn't order like bone scans or anything else? Or
No, after the biopsy, I did they did a PET scan to make sure that there's no metastasized prostate
okay,
cancer.
so
And so the problems that I have seem to be localized in the prostate, and the idea is that that, that gives me what they're telling me is an over 80% chance of getting licking the cancer over time using the combination of ADT and radiation therapy.
do you know if that was a PSMA PET scan or did they name it that way or just called it a PET scan?
They just called it a PET scan. I don't know what kind of PET scan it was.
And what's the hospital you're being treated at in Phoenix?
Um, I mean, did the biopsy at St. Banner Hospital. That's just where the doctor had took me. He usually takes people in his surgical center, but because I have a sleep apnea issue, they the surgery center said, you got to do this in a hospital in case anything happens. So I did it at Banner, and they were great. So that was the biopsy. And then I did the PET scan afterwards, and they said, we're not dealing with metastasized tissues here. And so I'm under treatment.
Right.
But this is brand new. You know, the whole process, being under treatment, is brand new for me.
So you went to 2 different places for the scan and the biopsy. Who's your Dr. Kletcher is in a particular practice? Is it a urological practice? Or?
Yeah, he's a urologist
Okay.
in Phoenix. They have a big urology practice in Phoenix.
And you said there was a team, so is the radiologist in the same practice with him? And
Yeah, they're
okay.
associated with
Yeah,
together, and they share the same information and stuff.
Yeah, I went a similar route with local practice. Felt
Right.
like I got pretty lucky. So,
Yeah,
well, I
I mean, they
also,
seem pretty good. They're the people who do the radiation are, you know, they have a center that just does that. And they have an oncology center. I don't have to go back. I have to go back to the hospital to get in a few months after. Well, there's the PAA procedure. I don't know if anybody's been through that. That's the procedure to reduce the blood supply to the prostate and shrink it.
no, I
That's something that
personally am not familiar with that. I believe I've heard it discussed in our groups before.
oh,
John or Rick?
it's something not used as it's not a treatment for prostate cancer, but in my case, it's a treatment for enlarged prostates.
Yeah, I feel like I've
And
heard it before.
yeah,
This is
and
an embolization procedure.
yes,
Okay.
correct.
Uh, it would be effective in killing a section of your prostate. Was your disease on the MRI bilateral or just on one side? Might have to be considered.
I'm not. I think it's on. I'm looking at the findings.
So the urologist will want to consider how much
I
abnormal
think,
tissue there was in that
yeah,
Pilates 5 lesion.
yeah. They're. I mean, like looking at the let's see, biopsy. The biopsy surgical report said that like the
I'm not
left.
100% sure that you will even actually need the embolization procedure.
Well, I had this discussion with my GP, who was not sure about this, and he's had a conversation with um, the interventional radiologist, and this PA procedure is being recommended both by my urologist and the radiation guy, who said that it'll help the
Okay,
radiation
then
therapy quite
then
significantly.
you won't be at a high risk because of your hypercoagulable
No, that's
genetic disorder.
this right at this point they say no, that I
And do
would
you
not.
sleep with a CPAP machine?
Yes, I do, quite
Okay,
successfully, and have been on
great.
that for years.
So Tam,
uh,
you said you had some cores were 3+3 and some were 4+3.
yes.
Did they give percentage readings on those in your results?
Um,
If you have them with you.
yeah, let's see the percentage. Um, let's see. I don't see anything that says percentages. Like the first result says left lateral mid prostate ROI biopsy, um, carcinoma, Gleason score 4+3+7, measuring at least 7 millimeters, involving 5 cores, grade group 3. Like that's the kind of description I got.
Yep.
That's the worst one. The
Yeah.
others are smaller, but there was another one that equaled 7, a 3+4, and a three
Right.
plus three for 6, and a 3+3, a 3+4.
Yeah. So once
That's
they
it.
give you a bigger number, don't worry about the smaller number. That's my personal opinion.
Okay. Okay.
They give you a 3+3, then you got a 6 Gleason, but then they say you had a 4+3. Now you're a 7 Gleason, right? So in your grade group 3. So Rick
Right.
has his hands up. Rick.
You guys keep going for a second.
Okay. Yeah.
Okay.
I keep
I don't
saying.
know if this made a difference. You asked about the extent of the prostate that's effective. They come up with like a whole bunch of sections that they look at.
Right.
And the left, they've got several sections. The sections that I told you about were positive. So there were about 6 places overall that were positive. Then they said left prostate apex biopsy negative. The left prostate base negative. The left prostate mid is negative, and the left prostate apex is negative. So I think that means it's sort of on one side.
Yeah, if I heard you right, it's a unilateral instead of bilateral.
I guess you mean like on one side.
Only on one side. Yeah.
Yeah.
Yeah, Tam, how many cores did they take and how many were positive?
There were 6 that were positive, and they took a whole bunch more. He did a extensive
Okay.
multi-core biopsy.
And was your original biopsy transrectal or transperineal?
Transrectal.
You see, I
Why would
have
that
a
mean?
few.
Yeah.
Well, it means that they may not see everything. It's also higher risk. We
That's
have.
one of the things that the radiation guy was telling me. He says that I asked him, I said, are you treating just the spots or are you treating the entire prostate? And he said, no, you treat the whole thing.
Well, yeah, it would not be focal radiation. I guess there are a few things that would give me concern.
Mhm.
First of all, let me just say several of us on this call have done extensive hormone therapy.
Okay.
I did 28 months. Dr. John, I don't know how much you've done, and you've been on and off, and you've been on more than 1 or 2.
Pretty much the same as Rick, about 2.25 years.
Yeah, but Dr. John has also done a secondary, which wasn't around in my day when it was there. Bill has done months and months and months, so we're really familiar with the impact. You're lucky that you got onto Orgovix. It's a great choice. I'm really pleased to see that that's what they put you on. It makes a lot of sense. I'm concerned about some of these.
What they're talking about for me is a short, assuming that the radiation goes well, it's like it would be a short-term thing, the 6 to 8 months
Right.
on the
And 6 to
ADT, and
8.
that's it.
Yeah, well, 6 to 8 months is typical, but you see, again, I would not proceed with those terms until I had that biopsy reread, because if it's 3+4 and not 4+3, then it would be 3 to 4 months. So you could be doing twice as much without having the confirmation, and the local
What
eye
One is
Phoenix.
4+3, and another one is 3+4,
Okay, so the question
and then
is how much?
there's several that are 3+3.
Okay. So what we're concerned with are those cores that are 4+3 and 3+4. How many cores? How much 4 there is in each of those cores, and whether in fact it is 4. And that's why we would want you to get a second opinion to confirm that. Now, once we know that, then we can decide on the right type of treatment. Let me ask you a couple more questions.
Sure.
How large is your prostate?
Oh, it's pretty large. It's
How
over
large?
130 milliliters.
How many cc's or grams?
I think it's about the same number. If I understand that correctly. It says 132 milliliters. I
130.
think
Yeah,
it's
yeah.
and they
132 is so.
over 100
132
grams.
is definitely large, and I can see. I would say to them about that procedure, they're going to want you on that ADT for about 4 to 6 weeks before they start the radiation. That's typical.
Right.
Isn't that
Yes.
right?
That's what you said.
So
Yes.
I would have them measure your prostate at the end of that period before you commit to doing this, whatever process it is, which I'm not familiar with. But the ADTs should shrink your prostate. So we may shrink your prostate enough to make to make it manageable. One of the concerns that I have when you are treated at a community practice
Mhm.
is that, I shouldn't say I would say we have, is that there is a financial conflict of interest. And they're going to treat you with as much as they can to make more bucks. And they do it all the time, which is
Mhm.
really one of the reasons why we tend to navigate people to centers of excellence. And we've been doing this a long time. We going back to 2010,
Mhm.
when I started on this path. What type of radiation are they talking to you about?
I do have some information about that. Let me see. It's not the
Is it
short,
SBRT?
intense. Yeah, that sounds familiar. Let me see what it says here. Um,
How many sessions are they talking about giving you?
it's 9 weeks. I think it's SBRT.
Well,
It's
it wouldn't be SBRT
or
if
no,
it's
not
9 weeks.
SBRT. IMRT. Does that sound familiar?
Yes. So
Yeah, it's
the first,
IMRT, and he said that something else. It was there was another
IMRT's,
description to.
Tam, IMRT's close enough for government work.
Okay.
So the question really is, and it may have something to do with the size of your prostate, but I think that if that were the case, I'd be going through these other procedures first. Why they're not giving you SBRT? And is it because they don't have the equipment? Because a lot of times that happens. They don't offer you the SBRT because they don't have that equipment, and then they've got to send you somewhere else. This, I don't know with the prostate starting out at 132 if you're going to be eligible. I do know that I'd wait to see how small it comes, because we can do in a week or 6 days what they're going to do in 9 weeks. So why schlep back and forth for 9 weeks if there's an option? And I would be wanting to get a second opinion on other issues. The other question is, could we do this with HDR brachytherapy with a large prostate like this, which might be a possibility, which could be done in 1 or 2 treatments? So there's a lot of issues
Well,
before
I know that I
before
asked the
you rush
urologist.
into treatment.
Yeah, I did ask the urologist about other types of options, and he said because of the size of my prostate, it wouldn't be a good candidate for other types of treatments. SBRT how's that different from the IMRT again?
So SBRT is, you might be more familiar with something called CyberKnife, which is just one manufacturer of SBRT, but
Hmm.
it is a more intense type of radiation where we can do more in one shot, and has proven to be, in clinical trials, equally as effective. And we often see in community practice that the doctors who don't have that equipment undersell it. So really what I would be saying is, get over to a center of excellence and ask them in the center of excellence, am I eligible, before you got
Hmm.
start off? Because the difference between getting treated in 6 days, 1 week and then one more, or in fact, UCSF, they only give 4 treatments, even though 5 are usually given, because they don't think you need the 5th treatment. Then you do it
Hmm.
all in 1 week, and 1 week is a bit different to 9 weeks. So now, at the same time, I frankly don't know enough. Um, as to the implications of the larger prostate, but I would not rely on a single opinion on a situation like that. I'd also definitely get my slides reread, because I don't want to be doing 8 months if it turns out that that single core of 4+3 that you mentioned is read by Epstein or Zhao as a 3+4, because that makes a big difference. You know, one of the things that happens with community practice is that they're good salespeople, and they want you to get treated there because they make money off of everybody. And we are very leery because we've seen hundreds and hundreds of men over the years. We've been running these groups 15 years now, and we've seen hundreds of men who think they've got the best doctor since sliced bread. They don't have the right questions to ask, and sometimes the doctors don't even give the right answers. And then people come back and say, well, they said this, they said that, they said the other. And we say, well, did you ask this, that, or the other? So
Mm-hmm.
I'm just raising some issues. Since you're on the ADT, you have plenty of time. And I would be going to, if your insurance allows you to go to Mayo in Phoenix, I would be going to Mayo to, I'm just blanking on the doc. I can give you a name in a second. I'd be going to Mayo. I'd be going to City of Hope. I mean, those are the two places, as far as we're concerned in Phoenix, that have the better prostate care if you want to stay in Phoenix. But I would not be running into, and I certainly would be running these treatments, these extra treatments. The other thing I wanted to ask Dr. John, because I know he's somewhat knowledgeable. It isn't his field of training, but I know he's somewhat knowledgeable on the oncocardiology issues, is about the implications of the hormone therapy with the warfarin and the Eliquis, because I know it's a field that Dr. John is familiar with. So we'll come back to that. But the first thing I want to do is I want to put a question in your mind about, is this the optimal treatment plan for me?
Specifically the radiation therapy, the
I
IMRT.
think the radiation therapy is definite, but there are lots of alternatives with radiation therapy. And when you're starting out with a prostate of that size, which is considerable, I mean, anything over 90 is considerable. It's not, I've seen 150, I've seen 190. So it's, but it is large. But if we can shrink that down, it may well change your treatment options. You're not a candidate, definitely not a candidate for low dose brachytherapy, but you might be a candidate for high dose brachytherapy. And you know, again, that it's another consideration. But I also don't have a real good feel as to how much cancer there is. It sounds like there's one lesion that's 7 millimeters long that's a 4+3, but we don't know exactly how much 4. And of course, we'd want to confirm that was 4+3 and not 3+4. And then the other thing is, we don't, I don't know how big that 3+4 was. How, the
3+4s.
Yeah, you said there was one 4+3, one 3+4, and the rest of them were
The
3+3.
4+3, okay, the 4+3 was 7 millimeters. There's a 3+4, which is 2 millimeters. The 3+3 of one.
Don't worry about the
Small.
3+3s, but that
Okay.
I'd like to.
And then there's
I'd
one
like
other
to,
3+4, which is also small,
okay.
although
So
it's rated 7.
okay, but for example, if those, first of all, 7 millimeters is not that big anyway. It's enough, but it's not that big. The 2 millimeter ones are both small, and the percentage of 4 could be relevant. But I really would want to get a second opinion on that, because if, for example, all 3 of those were actually 3+4s and the biggest you had was 7 millimeters, it could be you're a candidate for active surveillance and we don't want to treat you. And if we don't want, if we can If you're comfortable with that, which you may not be, but if you're comfortable with that, then for us, it's success to get a guy onto active surveillance with a really solid doc who's going to support the active surveillance until you need treatment. And I feel like we haven't taken those steps, and that you've been talking to doctors who are interested in treating. So I don't know. Let me throw it out to the actual, because I'm not really a moderator in this group. I just attend. But let me throw it out to
I thought he was
Stuart.
running. I thought he was running the group.
And not only that, I'd like to hear from other guys in the group who are in similar situations. There's some of you guys have been through this before.
Yeah.
Let's hear from you. Use the hands up function. Nobody?
I have something to say. I kind of second Rick. I second Rick, Tam, and not only my personal experience, but also the many stories. I've been involved with AnCan for 10 years. I've been getting on these calls for 10 years, and I've just heard over and over and over again. Guy goes to a urologist, gets a biopsy. It's got a 7. This guy says, "I get a prostatectomy," just like that. Get a prostatectomy. It's changed in the 10 years since I had my prostatectomy. I was initially diagnosed a little higher than yours, but it's changed to where now people are. There's still doctors out there that right away say either do the prostatectomy or do the radiation, but there are doctors that are starting to, say you're welcome to a second opinion, or active surveillance is a viable option for you, or something along those lines. But there are still doctors out there, and we still hear it. You're a case in point. We heard it tonight. Right away they say, well, you're 75. We probably don't want to do a prostatectomy, but we'll definitely do radiation on you, right? So as Rick said, a second opinion on the biopsy would be a good starting point, definitely. Going to Mayo or City of Hope in Phoenix would be a good second opinion from that aspect also. So, and don't be afraid to tell your doctors that you want all of your information sent to Mayo in Phoenix. I mean, no hard feelings, but it's your body, right? It's your life. So be your own advocate and do what's best for you. Find out what's best for you first, and then get it done. So, anybody else in the group that has some of our long timers got any advice for Tam? Anything that you went through that might be relevant? Stuart, what do you think tonight?
Well, yeah, I think it's really important that you get an independent second opinion on the radiation options, because they could be significantly different. It may be that your doctor already has zeroed in correctly on the fact that you need to go the long course. But
I didn't say this, but I'll just share what my doc said about that. He feels that the longer course is easier to go through and more effective, rather than doing a shorter course that's more intense
Okay,
and has more side
so let
effects.
me respond. Let me respond to that.
Okay.
In one word, bullshit. And if you like,
okay.
We'd be happy to send you the studies. It's been studied extensively. There was a study in JCO ASCO just recently, yet again from, I think it was SWOG or ECOG, it is not inferior. Now, the question I would ask him is, do you have an SBRT machine? Have you asked him that?
I didn't ask him what machines
So
they have.
my
I think he said
guess is he may not have an SBRT machine, because that's the sort of rubbish you get. Now, he can say to you there's no difference between the two, but to say to you that SBRT is inferior and causes more side effects, we know for sure with long-term studies that there is no inferiority to SBRT over IMRT. If I have a second afterwards, I'll send you I'll email you the studies. But
I'd like to
that
see that. Yes.
really bothers me. That really bothers me because that's not right.
Hmm.
That's white shoes talk to me, Tam.
Yeah, and Tam, if we don't have your email address and you would like to put it in the chat window, we can capture it that way.
I have it. I mean, we
You have it?
can.
Rick has it.
Well, yeah,
All right.
we can. I'll use the one you usually use. If
We got
that's
a
okay.
couple of guys with their
Okay.
hands up, but I will say that I did the long course, Tam, and I didn't think
Of
there
course, of
was.
what? Radiation?
Yeah, and I didn't think there was anything easy about it. Maybe the first couple of weeks, but then after that, it was not easy. So, Boykin, you had your hand up first. Go ahead.
Sure. So Tim, I heard you say, I think earlier on that you were also trying to balance other health concerns. And
Yeah.
one of the things that I did as I went through this process, my decision process, is that I tried to balance all of the different uh, health issues. And so I even had my uh, other doctors and exchanging notes and thoughts with those doctors so that I felt like I got a more holistic perspective on what to do, as opposed to just getting just maybe, one or two, or making sure that, you don't, you know, fix something over here, but break something else someplace else, if you follow what I'm getting at.
Hmm.
All right, Paul. Paul, you had your hand up.
Yeah, you guys hear me?
Yep.
Okay. Did anybody suggest to the gentleman about possibly getting a Decipher or Terra AI test?
Now, did you
Can you
have any
repeat?
type of?
Yeah, I didn't understand the question because he was kind of garbled there.
Oh, I'm sorry. So, did anybody in the session here recommend or suggest or mention if the current gentleman get a Decipher or Terra AI test?
Oh, the Decipher
So,
test is a genetic test, right?
Right.
yeah, it's a
Correct.
genomic test. Yep.
Right, right. I did speak to my doctor about that because my GP wanted to see that test, and apparently he recommended I do something called a Polaris test, which may be, I think, a similar type of thing, where it's a genetic test. And I know that he's trying to get that to happen on the samples.
Well,
I haven't gotten the
but
results yet.
again, Tamir, I mean, it's too quick. They're moving on to the Orgovics too quick. They're pushing you through this stuff. We need a Decipher back or a Prolaris back to give you the information so you can be your best advocate and you can advocate for yourself. And they're doing this stuff. Paul's absolutely right. Yeah, I mean, all this information should be in your hands before you decide to start on the Orgovics. I mean, if it were me, I'm not a doc. I can't give you medical advice. Dr. John can give you medical advice, but I can't do that. But if it were me, I'd get off the bloody Orgovics right away. I wouldn't keep taking the Orgovics. It reverses very quickly and say, I will take the Orgovics once I decide this is the right treatment path. We don't know it's the right treatment path yet. There's more information. There's a lot more information you need. As you know, Stuart went through a whole long period. Paul, God bless him, I think he was with us for about 2 years, year and a half before he finally went into treatment because he progressed and he made the right decision. And there is a lot more. John S. went through a long procedure at Memorial Sloan Kettering before deciding to take the leap. These guys are moving you into treatment, and in my view, you don't have enough information to know it's right. You need second opinions on you need your Decipher score to know what your risk level is, or Prolaris score. You need a second opinion on the biopsies. You need a second opinion on the types of radiation. All these things. Radiation is the right choice, but what type? But maybe you don't even need treatment. I mean, we've got guys who Eric just joined us, and we've got guys who have been on active surveillance, even though most community doctors would operate on them tomorrow. And they're progressing and they may need treatment in the end, but you're not there. In my view, if it were me, I would not be ready to make that decision yet. Dr. John.
We do have Paul to get to, guys. So
Okay.
Yeah, well, I'll only respond very quickly then. Absolutely, the more information, the better. We've learned that when important treatment decisions are at stake, we want to get real expert opinions. That's why we encourage people to do that.
Rick, I'll just ask you to send me the name of that doctor too. If you have a recommendation at Mayo.
Well,
Phoenix.
I'm sending you a message right now. You want me to use your ME address or your iCloud address?
They're the same.
All right.
Which one do you have? You have the one
I have both the ME address and the iCloud address, whichever one.
The Tamworth 27, that one.
I have that one, and I have the other one, which is ME.
Yeah, use that one. Yeah, use that one. The iCloud address.
The other one that's ME. Okay, .me.
No,
okay,
the iCloud. Excuse me, the iCloud address.
Okay, I'll use the iCloud address. That's what I'll do. And I'm sending you a message. I'm sending you a message, right? Okay.
Okay.
All right,
Thanks
Tam.
for the input.
I know we gave you a lot of information, and that's why you're here, is to get the information. And I hope you don't feel too overwhelmed.
I don't feel overwhelmed. It's just, it's like,
yeah.
I don't know if you have you don't want to kind of, I guess I'm worried about asking my doctors to reevaluate or to.
I will tell you, I felt exactly the same way, Tam. At first, I didn't even like my urologist. He came in the room.
Urologist. Yeah.
He came in the room and he shot a bunch of information at me like a scatter gun, and then was pretty much ready to leave. And I was like, "Well, hold on a minute, man. I got some questions." And once I slowed him down and got to talking with him, he had a wealth of information, but I had to figure out the right questions to ask him, and AnCan helped me do that. So don't be afraid to go back to your doctors and tell them you want more information, be it from them or from another doctor. It's like I said, it's your health, man. And
yeah,
okay.
Bill, can we just ask Dr. John to say a few words on that, because it's right in his wheelhouse.
All right.
Go ahead.
These folks are very used to people getting second and third opinions about this. It's not it shouldn't faze them, and if it does, that's not a good sign. So yeah, don't worry about that, particularly when you're talking about cancer. Everybody gets lots of opinions.
Okay. So yeah, we're gonna move on to Paul, and so Paul, you've seen what we do.
Bill, if I want to get
I'm sorry, John.
edgeways because
I thought you were done. I'm sorry. I apologize.
No, I just have to leave on time, but I want to tell you, I met Paul last week. He was diagnosed less than a year ago. I don't have enough medical information to present him, nor even to say for sure what group he belongs in. So take it away.
Okay. So Paul, you know what kind of questions you're going to ask, your age, your diagnosis.
Let's see. I am 70.
70.
I'm 70. In Little Rock, Arkansas. I'm being treated at the UAMS, which is the main teaching hospital here, with proton machines and all that sort of stuff. I think if anybody knows what they're doing in Arkansas, these guys do. I had a radical prostatectomy after really bad biopsy results. My PSA, when I hadn't had tested for years, my PSA was 8, and it went from 8 to 10 between November and the operation in January. and the and I feel like the operation was the right thing. Let's see, there's a Gleason score 4 plus 3 plus 7 with tertiary pattern 5, grade group 3 plus. Large gland expansile cibriform morphology, non-focal extraprostatic extension is present, invasion into the right seminal vesicle. Surgical margins positive for malignancy at the left and right apical margin and left posterior. Pattern 4, let's see, 61 to 70%, 70% pattern 4, 2% pattern 5. The 40% of the 31 to 40% of the prostate had tumor. Anyway, linear length by margins involved by carcinoma was 16 millimeters. Anyway, I basically feel like having the thing taken out was probably the right decision. I got the day the biopsy dropped, the head of urology for UIMS called me like instantly and said, "This is a surprise." And I did consult with other doctors. I didn't go to Mayo or anything to get a second opinion, but I felt and still feel like the decision to have a radical prostatectomy was, I don't know. I feel like it was the right one, and I don't. It's too late now, so I don't want to second guess it.
Well, I'll say that
Since
I'll say that you've already had the prostatectomy, and one thing we
yeah,
discuss in these groups is we discuss treatment regret, and
yeah,
I always tell people that at first I thought about it, but now 10 years out, I'm like, who knows what would have happened if I had done it a different way? I don't, and nobody
right,
else does either. So I'm still
yeah.
here and I'm still kicking. But so
But
you
yeah, I
had
don't
a
have treatment regret
prostatectomy
now.
already. So
Yeah,
you
I
have
had that in January. I've been completely incontinent since January.
what brings you to the group now? I mean, if you had the
Okay,
prostatectomy,
I'll tell you. When I was through the prostatectomy, my PSA was 0.04, um, and then it went up to 0.05 in my first check 3 months later, and now 2 months after that, it is at 0.15. So it's trebled.
so
It
yeah.
trebled in 2 months,
Well, I'll tell you
and
right off the bat, Paul. I think that you probably want to come to the advanced group because
okay.
you've had
Well, let me just tell
treatment
you.
and now you're having a
Let me tell
recur.
you. Let me tell you where I am now. Whether I don't know
Right.
if I'm in the right group or not. But if I need to be, what they're looking
Paul,
at
Paul,
now.
Paul,
Yeah.
Paul,
What?
we'd rather you didn't tell us because
Okay.
we separate our groups because we don't necessarily want the gentlemen in the low intermediate who haven't had treatment yet to hear this discussion. It's a very valid discussion. It's an important discussion. It doesn't belong in this group.
Okay.
Okay?
Well, let me ask.
Because,
Let
No.
me ask a question. Just let
yes.
me ask one question. If I'm not in the right group, then okay, send me an invitation to the right group. They're starting. They've got me on Orgovix
Okay.
as
Let's
of
just
2 weeks.
please can we hold the conversation right now? This
So
isn't the right.
Can I ask one
All I
question? Let me just, if I can. Let me just
Ask
ask you.
ask the question, but please don't give us any more facts if you don't
Fine.
mind.
Okay. My question is, well, let me just. Okay. I had an artificial sphincter installed, and they'll be activating it on September 29th. I was going on the assumption, and they seem to be saying, okay, we'll start radiation as soon as the sphincter is activated. And now I'm like thinking, Jesus, maybe I should be waiting for a while.
Okay.
Maybe I
yeah.
should do that.
Let's
And,
take
and
that
if I need
question.
to take it, if I need to take it to another group, just tell me
Let,
when.
let, let's take that question. We'll let Dr. John take that question because he has peer experience. And then please come back tomorrow at in this same room at you're on Central in Arkansas,
Yeah.
right? So please come back tomorrow at 5 o'clock Central in this very same room. We are
5 o'clock Central. 5 o'clock Central.
5 o'clock Central
Yeah.
in
So it's
this
four.
very same room. And that is our high risk recurrent advanced group, which is the group we should be having this discussion on. We'll give you time. You can get into the details. But I would like Dr. John, in case he's not with us tomorrow in that group, I'd like Dr. John to respond to your question about the AUS and what he thinks you should do. And he'll, if he feels that's a question for tomorrow, he can pursue it with you again tomorrow. John?
So your question, Paul, was whether to go through with the scheduled activation?
No, the scheduled activation is going to happen. They're scheduling
Okay.
radiation, and I'm on Orgavix. And my question is whether I'm having a PSA test tomorrow. I had a PET scan, another second PET scan today. If those look okay, should I just be waiting for full healing of the AUS before proceeding with radiation? Like that. That's
No.
my question. But
No, I
no,
don't think so.
just continue. Just plow ahead.
I think it'd be okay.
Okay.
Yeah, good question. Okay, see you tomorrow.
Okay, see you tomorrow. 5 p.m. Central Time. Okay, I appreciate it.
All right. So that was all our new guys. A bunch of people are hanging up. Call's not over yet.
9:36
All right, that was it.
p.m. East Coast.
That was all our new guys. I know that Richard in Silver Springs, you said you wanted to bring something up. So
Yes, thank you. First of all, I hope I don't trigger any tripwires here, because being in the low and intermediate group, I've always thought that this would be some post-treatment issues. I had SBRT treatment 16 months ago, and I'm going through what I've heard in this group before on some side effects, which I kind of expected, which is restricted flow of urine, discomfort, and then urge incontinence about three times a day. Since the SBR treatment 16 months ago, and with these past side effects, I have had 2 bladder ultrasounds, which have been indicating that there's retention in the bladder. Well, so the doctor's been monitoring it. The PSA is declining. It's going in the right direction. But recently I had a blood test, totally different issue. But on the blood test, there were 3 factors that show some very high readings indicating problems with the kidney. I'm not going to detail out what each one of these little items were in a blood test, but my question to the group is, since this is just very, very recent, like a week old, that as I Googled some of this information, it says that these high readings could be due to a blockage in the urinary tract. So I'm wondering if anyone has ever had any other issues of side effects outside of the prostate, such as with the kidney, due to problems with the urinary tract, because the area I was treated for had the urethra went. Let me get this in the camera here. Yeah, went right through the center of the area to be treated. So it was completely encircling the urethra. And I wonder if anybody has had anything similar that has led to other issues outside of the prostate, such as kidney. So I hope that topic is under the purview of this low to intermediate group.
yeah. I personally didn't have any kidney issues. I had bladder issues, but that was radiation related. But Boykin, you wanted to say something?
Yes. So I have kidney issues as well as the bladder issues. And Richard, I went through something similar to what you were talking about. about 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 a 2 to 3 months after I had my radiation, and they diagnosed it as radiation cystitis and or irritable bladder syndrome. And they just gave me some meds, some oral meds that I take, and that over time it just clears up.
Oh, okay. Well, all right. Yeah. Well, let's hope so. Because
Yeah.
they have you going to
Well,
see a kidney specialist. I'm on 2 meds now to help with the discomfort and to increase the flow of urine. So I'm just wondering if the blockage is affecting the kidney. So, but I'm glad to hear that you had something that has been resolved, going in the right direction.
Right. Yeah. It was just a side effect of the radiation treatment itself.
Now, let me ask you this: Did as a result of that, did you report that to the VA? Give me about 30 seconds on this, Rick. I know it's a veterans group, but did you link this to prostate cancer, the issue with the kidney, and did you report it?
Yes.
Okay, all right. So I'll bring that up with you.
So yeah, when
So,
if you had the treatment and you had the blood test showing this in your medical records, anytime you do your reports to the VA, you should include all of your medically.
Okay, all right.
I forgot the word I was going to use now.
Okay,
Relevant.
Secondary or tertiary conditions.
Yeah, relevant. It's relevant
Right.
because it's in the same area where you were treated, so they're
okay,
definitely going to take that into account.
all right.
and
Thanks,
Rick, go
thanks.
ahead.
Yeah, thanks for
this
that feedback. I mean,
discussion, no,
I've been on a brief sabbatical, and I haven't been able to bring that up in the veterans group yet. But I appreciate that, and I will bring it up with the other group. Thank you.
Rick?
so the discussion is fine. What we talk about incontinence, we talk about ED in this group. We talk about side effects in this group. So that discussion is fine. What we try not to talk about is when you have a recurrent situation and the subsequent treatment from recurrence. That's what we avoid.
Gotcha.
And
Gotcha.
and if you look at the reminder, I think the reminder says we don't discuss recurrence in this group.
Yeah.
And there are good reasons for it. And it's not that we don't have the knowledge. We do it out of respect to the gents who choose to join the low intermediate group.
Gotcha.
Yeah. Paul?
Hey, yes. So one thing, just to follow up with Richard's statement here. So for my history, and I think I told you guys this, when I went to my radiation oncologist, I wanted to do the 5-day treatment because all the pros uh, with that, but he refused to give it. He refused to give me that treatment. And I asked him why. So basically, his concern was because my tumor was so too close to the urethra. Therefore, he said that's more risk than he's willing to accept with the radiation. So I want to do the 5-day. He said no. And I asked him again. He said no. And then the other thing, basically, kind of confirmed to what he said. I took the prostate test, and some of you are familiar with that. Just in summary, they you give us, they'll check you to see if you are at risk for the higher dose, shorter term treatment versus the longer, more traditional treatment. And the result from my test came back said I am high risk for uh, GU and GI complication post treatment, mid to long term. Um, so therefore, that's why I went ahead and decided with the 28-day treatment and, instead of the 5. And of course, the oncologist, one of the oncologists I went to, he refused to give me the 5 days, so I wanted 28. So that's, I mean, obviously nothing is proven 100% correct, but that's might be part of it too.
Yeah,
So I don't
see,
know. Go ahead,
Paul,
Rick.
the reason he didn't want to do the SBRT was because he was personally concerned about the position of the tumor.
Correct.
That's valid. If it were me, I'd get a second opinion on that, but not everybody would, but I would get a second opinion. But it wasn't because SBRT was not going to be as effective and likely to cause more side effects. And we know that's not the case. So there are situations where, and it may well be that in Tam's situation, the size of the prostate is the reason. That might be a
Sure.
good reason. It would still be worth getting a second opinion, but that would be a good reason. The reason that he was given, that IMRT is superior to SBRT, that's not a good reason.
Yeah, I fully agree with what you said, Rick. I'm referring more to Richard's question.
Oh, okay.
So,
I'm
and I
sorry.
shared this with, yeah, I shared with this with Richard. We've been talking, we've been on a journey together pretty much this whole time. So I shared that with him as well. That's everybody, obviously the tumor location is different for everybody. Mine just so happened is so close to the urethra per the radiation oncologist before he just refused to give me the 5 days. He has the equipment, he has the experience. He just said, I'm not going to do it for you.
Yeah, but but again, Richard can't change that. He had the
Yeah,
SBRT.
sure. Yeah,
Go
yeah,
back
yes.
on it. So, it's again when we comment, I don't want to encourage. I don't want us to encourage Richard's treatment of regret. What I want to do is relieve the anxiety from what's going on right now. See how we can help him, and hopefully he's not going to have a problem. I know that Boykin knows a lot about this area from his comorbidities. Um, there are other folks, and you might find more information in the more advanced group, Richard, and you're very welcome to come in and ask them. But it's also a very valid question for the guys in this group. We do see guys in the other group. We just had somebody recently who had a stricture. And we do see strictures. And to come in tomorrow and just ask what's people's experiences with strictures and kidney strictures, very valid comment. It's also a valid discussion in this group.
Okay,
All right.
that's a good tip. Thank you.
All right. So, Eric, you joined us pretty late. You got anything to?
Yeah, he was on a bicycle coming back from Los Angeles. And,
I'm on the subway. I'm just arriving at Atlanta late, but I'm
You,
good.
you're
Thanks for
good?
having
Nothing you
me.
wanted to bring up?
Yes,
Or?
nothing at the moment. I
All
know you
right.
guys are going late.
You
Eric,
just got back from LA?
Yes,
Ah, okay.
Eric, do you just want to say just a very quick for the benefit of these guys, and it's on the recording? Just comment on your prostate ID,
for sure.
because I think it's very relevant, and we really want to push that that group, that prostate ID seminar that we're going to have on the 17th. So these guys may be able to benefit from that. But give them
Sure.
a quick word on prostate ID. They probably don't even know what it is, so you may have to start at the beginning.
I know
Sure.
what it is.
So prostate ID is an AI interpretation of your MRI scans. And what it does is it reads the scans and basically 3D maps the tumor lesions in 3 dimensions, and they write up a report with a pyrite score, with the prostate size and the tumor density. And it's like what I like to call a spell checker. for the radiologist. So you'll have your radiologist interpretation. This is almost like a spell checker second opinion of the same thing, but you can actually see in 3D what the tumor looks like. And they can also utilize that for a biopsy, fusion guided targeted biopsy to help guide needles as well. It's pretty neat. It's only $259, and you can upload your scans through a portal online with an account. And I think it's usually overnight, and they send back a full report to you. And I'm happy to answer any questions.
And in Eric's case, it's flagging a possible change in treatment.
Yeah, it's definitely highlighting some hotspots that could be an upgrade or downgrade, however you want to look at it in terms of like the depletion score or something along those lines.
You talk to your doctor as to whether this is something that he can use for uh, a more targeted biopsy?
Yeah, I uploaded the report to my doctor. He's looked at it. And he's forwarded it on to another doctor who does transperineal, and they'll probably obviously look at that to gauge for targeting, fusion targeting.
Do you know, can they upload this thing into the fusion and use it
Yes,
as a target for a fusion biopsy?
yes, they'll also share a DICOM file, like an MRI file, that already has the 3D map overlaid as if it was the already in the MRI report. And they can utilize that with their software during the biopsy. Does that make
One thing
sense?
I thought that was
Yeah.
real interesting was that the guy at the PCRI conference who was speaking on scanning and MRIs and everything else, what was his name? Ramon, wasn't it? Steve Ramon? Ramon?
Sounds right.
He was a little skeptical about this prostate ID, and we moved him over to talk to the expert who happened to be present. And he seemed a little more sanguine after he spoke to the expert. Is that a fair assessment, Mr. Milson?
I'd say so. I mean, I wasn't there in that conversation, but he definitely seemed interested, especially since it's FDA cleared and all that kind of good stuff.
Interesting. Hey, Paul, you have your hand up. You got a question for Eric?
Oh, Eric and others and team, just in general, while we're speaking about MRI, so post-treatment, so for example, for myself, radiation, post-treatment, does another MRI bring any value at all for keeping an eye on the prostate and the tumor, or is it just strictly just PSA, continuous PSA testing?
That is a possibility. I would definitely discuss that with your radiologist, oncologist. And I don't know the nuance of that dynamic, but if MRIs are valuable after treatment in terms of radiation.
Yeah, I don't know,
But
the prostate get all mushy, so you're not going to see anything.
yeah,
Value.
maybe somebody else knows that answer.
Yeah, I just had a follow-up with my radiation oncologist this past week, and I'm 9 months out, and in a couple of months, I will have another MRI and a confirmatory biopsy. And his comment was, PSA reading is nice, but it's really the MRI and biopsy that are going to tell them how things are going after the fact. So the
Wait a minute,
follow-up
yes.
MRI, the follow-up
So
MRI after
Yeah.
radiation is a legitimate test that can help inform them.
Hmm. Okay.
But that
And even another biopsy post-treatment?
Yeah, well, I'm actually in a clinical trial, which is part of the reason
Oh,
why
okay, okay. But that's not
they're
No,
standard practice. Yeah.
doing that.
no, it wouldn't be standard practice to get another MRI post-treatment. No, they'll track it with PSA first, and then if there's other scans, of course, that have come out since the old days, I guess you'd say, if there were concerns for that.
Okay, okay. I'll have to ask my oncologist after. So I'm due for my 6 months in October, post-treatment. So I'll ask him. Thank you.
All right.
phase 4, is it a commonplace to wait a year after treatment to do the MRI? If you're at 9 months instead post treatment?
The way they approached it is we do PSA every 3 months, and assuming there's nothing untoward coming out of the PSAs, their standard plan was 12 months for both MRI and biopsy. But that was always with the proviso that if the PSA wasn't doing what they were expecting, that one or both could happen faster. But
Okay.
everybody in our trial is having the full 12-month follow-up.
Okay. Sounds like they let it heal and wait for it kind of thing.
All right, gentlemen, we have been here for 2 hours. We talked to 3 new guys and got a bit of information. So for you new guys, please, we hope you take to heart the advice we gave you, the suggestions we made, and we'd love to see you come back and let us know what you found out so far. And just so you know, AnCan's, we're here if you need us. So
Tam, did you see my message in the chat window? The chat window is the 2 little boxes. There's a lot of action that goes on in there. So you've got all the addresses to get reread. You can download that chat window. Those 3 dots at the very 3 vertical dots on the line where it says chat allow you to download the chat messages, and you will so you can do that. But I just wanted to make sure I sent you a personal message in there, so I just wanted to make sure you saw it, Tam.
all right. Tam, if you're speaking, you're muted.
Yes, Rick, I'm looking at it now, so thank you.
Okay.
All right, everybody. I think we had a good meeting. It was Jeff and Tam. Welcome to AnCan.
Thank you.
Wish we had met under other circumstances, but life is what it is.
Thank you, Bill.
Tam, how
Appreciate
did
it.
you hear about AnCan? I'm just curious.
Oh, well, from our original meeting, we were talking about what you
Oh my
did,
gosh.
and that was,
Okay.
we remembered that. So I looked it
Okay.
up.
Good job.
Huh,
Good,
I know.
good job.
Appreciate it.
Good job. Fantastic.
Hey,
Okay, I'm sorry to see you in this forum, but we're happy to help you.
Okay, thank you.
all right,
I'll be in touch.
I'm going to stop the recording and call it a night. If the
Okay. Good night.
moderators could stay on for just a second, I want to tell them something. So,
Yeah.
all right, good night, gentlemen.
Good night.